as we're discussing the pediatric exam, because this is something I'm extremely passionate about, and particularly when it relates to kids and adults, but kids with behavioral learning, socialization, or developmental challenges. And when it comes to chiropractors, us working with kids with these challenges, neuro-deflective disorders or neurodevelopmental disorders, and really you should boil this information down and say this really applies to working with anybody, but definitely working with any pediatric population. So I think first we should discuss just what are some of the challenges that we have. And let me tell you, this is not just a chiropractic issue. I work with neuro-optometrists, and they kind of, I see neuroeducators. We have kind of the same challenge across multiple professions and schools of thought, and that is that we don't necessarily have a great exam or clinical process that is whole apart, that is all encompassing, that tells us not just, hey, what do we do about a deficit, but how do we understand the bigger picture and have objective clinical measures and subjective and observational clinical measures, and take an appropriate case history, perform an appropriate exam to be able to say, okay, this took us out of the deficit model, which means like, hey, a kid comes to us and the mom says, my kid is having tics. I just right now just finished my last patient with a child who has Tourette's, who has tics. And we say, okay, well, I'm not treating the tics or the Tourette's. But what I'm looking at is, we know there's a reason for behavior, or maybe your child's having a reading challenge. There's a reason for that. And what we do in chiropractic is we don't treat the reading disorder or the tic. We are looking for clinical indicators through our exam, through our case history, being able to ask and answer the right questions there, and through our exam, being able to ask and answer the right questions there to really help us understand what's happening there with this child as best we can with our tools. And what do we do? What is our place? What are the indicators to us that we can help, besides we treat the tics or we treat the learning disability or whatever? We don't do that. But also not just stay in the lane of like, I don't treat that. What I do is correct subluxation. We know your child's going to be better if they're unsubluxated and uninterfered with. True. But how do you bridge the gap in your communication, in your clinical understanding, in your actual exam that backs up your clinical understanding, in the way you present it, in your care plans, using your exam and your re-exam to be able to say, okay, this is what we found on the exam. This is why we recommended this care. Mom and dad understand. And then this is what we're looking for on our re-exam. So we have something that tells us, oh, it's time to reduce care. Oh, it's time to increase frequency. Oh, it's time to add something else in, whether we're working collaboratively with another provider or we do other things in our office. We have different tools in our office that we can use in addition to the chiropractic. Wherever you stand on that, you still have to have something that guides you so you're not just treating the symptom. See, this is one of the massive challenges that we have. One, we don't have great exams in our profession. We don't perform great exams. And then when we do, say we're doing heart rate variability, thermography, palpation, postural changes, a lot of times it's just to check a box. I mean, if we're really honest with ourselves, I think a lot of us, and we've all been there, are kind of doing these different exam processes and procedures, not because we really understand what they're fully telling us and then how to use them again, but because they're really good communication tools, or because somebody somewhere told us, whether it was in school or practice management, but not because we fully understand what they're telling us and how they are a tool to help us understand what's happening with these patients and these kids, and then how to use that to guide our decision-making, our clinical reasoning and decision-making. So I'm just going to tell you, we do a lot of training on this in the certification series. We have a lower level, more intro course coming soon as well to get you guys some access to that for those of you that want it. But let me just tell you, and we do a lot of teaching on the exam in both of those, or in the certification series. But let me tell you what, in my opinion, from a brain-based perspective, what we really need to be doing and what we need to be having and how you can start incorporating some things you could start incorporating into your exam right away. This is what we really need to be doing. We need to be asking and answering the two big questions with our exam. Whenever a person comes to us, hey, can you help my kid with ADHD? Well, I don't know. We need to do an exam. We need to, our purpose of the exam, our objective is to ask and answer the two big questions. Question number one, and of course, all of this is based on what you know about brain development and what you've communicated to this point. Question number one, that we clinically have this amazing opportunity to be clinical investigators. This is the best part about our job, one of the best parts. It's very fun. First question, are there objective indicators? Are there indicators of input, processing, output inefficiencies or challenges? Input, processing, output. Are there clinical indicators? Is there evidence of input, processing, output, afferent, efferent issues, right? And where might we see that? Again, first question, are there clinical indicators of this? Where might we see that on our exam? First of all, we teach you how to take a targeted case history on that. Second of all, what are we looking at here? Subluxation, right? But what might we see? Well, my recommendation is in that first question for your exam, you need to be looking in two categories. First category, if we have subluxation or input, processing, output, we're going to see some evidence of that in potentially postural distortion, range of motion changes or alterations. Possibly if you take x-rays, you may see changes on x-ray, right? And this isn't a debate on if you do that. I'm giving you some things that you may choose to include, but there must be a structural component, right? A structural or postural distortion component to are there indicators of an input, processing, output challenge? If we have that, we're going to start to see some postural distortion in some form. We're going to see some range of motion or alteration in movement patterns in some form. And so we're going to look for, that's the first thing in a structural sense that needs to be somewhere in your exam. You better be, whether it's a baby, whether it's an older kid, whether it's an adult, we need to be looking at, are there postural distortions? Are there range of motion distortions? Is there evidence on x-ray that there is or has been? Right? So these are some things that you would look at there. The second piece of input, processing, output, looking for clinical evidence, the second piece of that in my mind that we must be assessing is we're saying this is a neurological thing. There's a structural component that we can visualize. There's also some evidence there needs to be some evidence in the neurological implication of this, or input, processing, output. And when the neurological evidence of that would be, thermography is a great one, right? Output, efferent, paraspinal asymmetry, and thermography. That's a great one. Understanding that, looking at that as one of the windows into, are there clinical indicators of input, processing, output challenges? 2, heart rate variability, where we're seeing alteration in autonomic balance. 3, if we're seeing tonal changes paraspinally, or just tonal changes, you can do that with surface electromyography. You can do it by palpation, by observation. You know, you're using your hands, you're using your equipment. There need to be some measures of that. The other one I love, which we talk about a bit in certification series, is, the eyes. Use a pen light. If you don't have heart rate variability, but you still want to get a measurement or an indicator of the autonomic nervous system and autonomic imbalance, get a pen light and look at the pupillary response. What you should be seeing is, when you shine the light, you should see a constriction, right? Constriction of the pupil. That should remain that way for 5 to 8 seconds. At 3 to 4 seconds, you might see this hippus, this kind of like movement, this twitching of that pupil, and that's normal, that's okay. But if you see a full blowout before that, like 5 to 8 seconds, really like 7 to 8, it's like referenced different ways, but like that 8 seconds, if you see a full blowout or dilation of the pupil, before that, not just a hippus and then a blowout, but if you see a full blowout of that, that's an indicator that we're more sympathetically dominant, this person. That would be an indicator to us, like heart rate variability would be an indicator to us. And you can all do it tomorrow. You all have a flashlight on your phone. You all have a pen light somewhere. You can use that as one of the indicators. So there's two questions that we have to be asking when we're looking at pediatrics. One, input, processing, output, subluxation, indicators of subluxation. When we look for indicators of subluxation as a review, we should see structural alteration, right? Some sort of postural distortion, evidence of that, and movement alteration, because we know that that's a component of subluxation. And two, neurological compromise. So we need to make sure, I encourage you, we do all of those things, but I encourage you to at least add in one or two of those indicators in each category. Moving on, the second question. When we're talking about pediatrics, we know that they are not fully developed. Their brain, their neurology is not fully developed yet. We know that the brain has to develop kind of like a flower, bottom up, back to front, inside out, right to left, finally in the front of the brain, ending in the front of the brain, that prefrontal cortex. And so we know that as we move through development, we gain more sophisticated tools as we move through development. So the thing is when we're talking about the pediatric population, we're looking at whether somebody comes to you for wellness and they're typically developing, whether they come to you with chronic ear infections. We know that this child is not fully developed yet. We know that they are in the process of moving through brain development. So if we're saying, hey, it's important that a child is unsubluxated, we don't have inefficiencies or alterations in the way the brain is receiving, processing, and sending information, we know it's important that they're unsubluxated, and we look for that in our exam, and they're better off. We better be able to look at, and we say, hey, we know it's important for brain development. We better have something to measure brain development. And so this is really great, because in the second question that is our obligation to ask and answer with our exam, chiropractors, because we know when we adjust the spine, we impact the brain. Well, specifically, we better be looking at the brain and brain function and development. And so the second question is, where is this child in that developmental trajectory? And what does that tell us about the tools that they're using to process their world? Which then tells us a lot about what the behaviors and whatnot that they might be having. Another story. Second question, what tools is this child using to process their world, and what does that tell us about where they are in the developmental trajectory or where their gaps may be? This is where we start to incorporate some really fun stuff. It's not complex. It doesn't take a bunch of time. You can do a super complex, and more in-depth assessment with just what I'm teaching you here, or you can start really simple. But it's bringing some of these brain-based concepts into your exam and into your communication, so you can monitor and you can have an appropriate clinical investigative skill set to watch development as you go, and then communicate that to parents and go from there. This is what we teach in Focus. So second question, what tools is this child using to process their world, and what does that tell us about where they are in brain development? Because we know that if we have altered input, processing, output, that's going to impact brain development, right? Or it can. We know that. And so we know that in early life, in the first year of life, we have these things called primitive reflexes. They are the tools that we primarily use to process our world in that first year of life. They are reflexive. In our course offering that we have, just a kind of an intro, I have a class just on primitive reflexes for you guys. We don't have it out yet, but it'll be out in the next couple of weeks. So you can grab that. It's just on primitive reflexes and really simplifying that. But really, just in short, these primitive reflexes, when we look at that brain developing bottom up, back to front, inside out, kind of opening up like a flower, we know that we have these different tools. So if we can assess those different tools, it can give us a window into where some inefficiencies are happening currently, or where some inefficiencies did happen in development, and that can give us a lot of information. And then we can reassess those as we correct subluxation to make sure we're seeing change, or then we know when to add other things in. So primitive reflexes as an exam tool, not as a, if I see it, I start to do those exercises with these kids. Use it as an exam tool, just like you would palpation or thermography. It's an indicator. It's a window into development. It's not to be starting to do, this is where people make a mistake with primitive reflexes. If they have it, if it's persistent, then I must start them on a primitive reflex integration exercise program. No, not necessarily. You can create a problem, but use it as a marker and then use it again as a re-exam marker. And then we can put all this together and simply know what to do and when. And we help you with this in the process of learning it. So look, second question, what tools are you using to process your world? Let's measure some primitive reflexes. Let's learn how to take quick measurements of some reflexes to say, hey, that reflex should have been in the most efficient situation of brain development. We should have seen that reflex integrate, but for some reason, it's still there a little bit. Let's mark it down. We have this lovely sheet here for our Focus Elite doctors, Elite Access doctors. It's like, it's still there. Mark it down. We're building a case. Then we move into gross motor function. Look, we should start to have, you know, as we integrate the primitive reflexes and the brain is developing along this trajectory and I always say respect the hierarchies of brain development. There's 8 of them. But as we move along these hierarchies of brain development, the next one to kind of come on board, as we don't need those reflexes guiding our show anymore, is movement touch. So our big muscles first and then our small muscles. So we should have a gross motor assessment. Basic gross motor. How does this kid move their body in space? Can they cross midline? Can they jump with 2 feet? Are they 6 and they can't do that? Can they not skip at that point? Can they walk heel to toe? These are all different things that we should be assessing quickly to give us a window into that system. Gross motor, fine motor. How do they color? How do they hold their pen? When they hold their pen, or their crayon, do they, have to elicit big muscles to do this? Or can they hold it? Do they just hold it appropriately? There's we could do a whole discussion on this, but you're just starting to observe. Can they do a finger tap like this? Can we do that? Or is it difficult to get that fine motor function and differentiation? What happens when you try to get them to do that? So we're looking at primitive reflexes. We're incorporating some gross motor assessment. We're looking at fine motor. We're looking at eye movements. That's one of the next things to come on board. Well, before that, we're looking at auditory verbal. How are they with receptive and expressive language? Observation of that. If I play a metronome, can they clap along to the metronome? Do they even hear the metronome? Not just can they hear, but do they attend to it, right? In that 2nd to 3rd year of life, we really should be attending more to auditory verbalization and then making our own auditory verbalization back. So that's where we start to have more sophisticated receptive and expressive language. We need to measure that just quickly. Just make it. You don't even have to know everything it means, although we're going to teach you more and more about that the more you engage here. But just take a measurement of it at this point to use it as a clinical clue of, hey, what tools are you using? And what does that tell us about how you're using your brain and where you are in development or where the gaps may be in development? And then we'll use it as a reassessment as we go. Right? Eye movements, basic fixation and convergence. Can your patient converge around 18 to 32 months of age? We start to be able to have this convergence. Do we have trouble when you try to get them to converge on a near target? Do they tip their head and try to go into monocular vision just using one eye? Well, that certainly could, if their visual system isn't fully developed yet, which we should start to be able to have some convergence. It starts to develop in that 18 to 32 months, but not like you're going to hold a target for a long time for a baby that age, but like at 5 and 6, we should be able to start going near target, far target, and doing this accommodation exercise, near and far, divergence, convergence, right? And we should be able to do that. Basic tracking patterns. Can we? Do we see it? And then moving into visual cognitive function. We teach how to do some basic story questions and assess visual cognitive function, but even just little things like, hey, if I have a 5 or a 6-year-old and I ask him, like, can you tell me one thing about your day? Can you tell me one thing that's in your bedroom? Can they do that? Can they recall something, visualize it, and tell you? Or is it something that's memorized? Or does it create too much stress? We should be able to start having this recollection at that 4, 5, 6, and outside of just as we become more sophisticated in ourselves, in our own bodies at 2, 3 years old, we start to look outside of our bodies, which is when we hear terrible 2s or 3s, because kids are starting to become more sophisticated in their self based on where they are in brain development. And then they start to attend outside of self, and they're trying to find boundaries. Is a child doing that? Do you have a 10-year-old who never did that, or who isn't doing that, who's just kind of shut down? We need to be able to go through and assess primitive reflexes, gross motor, fine motor, auditory verbalization, eye movement, so we can see, what does this tell us about that second question? What tools is this child using to process their world? And what does that tell us about where some gaps may be, where some stressors may have happened in the timeline of development? Where may we need to go back and fill some of that so we have better top-down function? Because here's the thing, we're building the architecture of the brain, and we're taking an assessment on that, which we know if we have altered neurological input and output, that's going to impact our ability to move through development. So as we restore efficiency in the nervous system by correcting subluxation, we better measure developmental progress. We say we restore efficiency by correcting subluxation and that it changes the brain. Let's measure it. Let's measure it. Let's watch and wonder. Let's have an exam that's congruent with leading with brain development. And then let's be able to have those very simple conversations with parents. And then let's do a re-exam so then we can know, when do we add in primitive reflex integration exercises? When should I talk about diet? When should I get the neuro-optometric professional on board? When should I do whatever? All of these other things, which are great. When, if, how, what's my place? Look, we have to maintain efficient neurological input processing output, but we need to measure and have indicators of bottom-up development. If we have holes, if we have gaps, if we have deflections, if we have inefficiencies in bottom-up development as evidence of persistent primitive reflexes, gross motor challenges, fine motor, auditory verbal, visual cognitive challenges, then we're going to have top-down challenges, meaning they're having challenges using their brain to engage and learn and connect with their world. So we have to be able to measure bottom-up to understand top down, why are they having the challenges they're having in their world? Then we need to, with our exam, be able to measure it, continue to go back to asking and answering the 2 big questions. This is how we communicate and have so much, I don't love the word certainty, it's so overused and in the wrong ways, but like if we really know this stuff and can lead with brain development, have congruent case histories, have congruent procedures, have congruent exams, by finding the simplicity on the far side of complexity of this stuff, and then learning and practicing, it's very clear where chiropractic fits into this puzzle with pediatrics. And it's not that we treat autism or we treat ear infections. It's that we are impacting the brain, and a pediatric brain is in massive growth. And if we have altered and inefficient processing or input and output, that will certainly impact the way the brain moves through development, which will impact the way an individual engages and learns and connects with their world for their entire life. So I have a lot more we could say on this. In level 2, we teach a ton, and level 1, we teach you the hierarchies of brain development so that we can start finding the simplicity in these exam processes, in your procedures, in your clinical understanding, so that it makes more sense. But for now, start making sure that you are using these 2 questions to guide your exam, and make sure that you have some clinical indicators to help guide your understanding of what you're looking for in the exam, and then use those as re-exam measures. Okay, everybody, I'm gonna go home and have dinner with my family. Hopefully that was thought-provoking for some of you. Hopefully you got one little jewel that says, or that helps you say, hey, I'm gonna add this into my exam, or now I understand a little more about this, or now I have a massive question on this and we're here to help you. But here's the deal. What we do does change the brain. What we do does impact the life of the family, of the kids that you're working with. But it's not enough just to say, we know they're better unsubluxated. We need to know a little bit more, or we get into this model where we start trying to treat the symptoms, even though it's not congruent with what our philosophy is and our science, and or we just ignore it, and we lose patients, and we don't have the opportunity to help people and build bridges with other professionals, and understand ourselves really what we're doing. This is a really fun way to practice. It's a really great thing to be able to see the wins and see the changes in expression of life, not just try to get rid of deficits. All right, everybody, have a great night.